Good evening, everybody. On behalf of Cardiology Society of India National Body and Cardiology Society of India Chennai Chapter, it's an immense pleasure and privilege for me to host the today's Cardiac Rhythm Council digital meet of 2020. And this is a special day. We are holding this for the last 6 days. This is the fifth day, and this is a very, very important day when it comes to Cardiac Rhythm Council digital meet, is because we are hosting today the pioneers of physiological pacing, and the theme of today's program is physiological pacing. And it is a proud moment for Cardiology Society of India to have the pioneers, appearing on our screen, on the screen, namely Dr. Pugal and Dr. Parikshit Sharma. They are going to teach us a lot, and they are going to be ably be accompanied by the pioneers of physiological pacing in India, who have done such a tremendous work in this physiological pacing that the whole world is acknowledging their work, and namely Shanmugasundaram and Neeraj. It's for me. It's such a pleasure to have all of them for today's evening. There's another special person here whose contribution is not so much recognized just because he had been only once to India, but at least in South, especially in my center, I should say that there has been a tremendous impact by his visit or his teaching, and that is Dr. Dale Yu. Dr. Dale Yu happened to be visiting us a year back. He is accomplished electrophysiologist. His work in 3D electroanatomic mapping and his work towards reducing fluoroscopy and doing certain procedures almost without fluoroscopy has impressed me, and he has got a lot of publications. So JLU is going to be actually starting off the first session. I would again acknowledge that Dale Yu is one person who actually helped us in physiological pacing to do it much more scientifically, not only by the conventional fluoroscopy, etc., but also by the 3D electroanatomic mapping, and his contribution had been tremendous. So on my screen, when I see Pugal, Parikshit, and Dale Yu, I think it is really complete from the standpoint of physiological pacing. So we have President of Indian Heart Rhythm Society today, Anil Saxena, on the screen. We have a Vice President of Indian Heart Rhythm Society, Dr. Ajay Naik. I think it is really, really a complete session for the day. And I wish every audience, and the audience response is also quite great today. I hope they will have a great time. And with these words, I would like to hand over the session to Dr. Dale Yu, who would introduce Pugal and his co-moderators, and then he will take the discussions on. So welcome everybody, Dr. Dale Yu, to start.
Thank you so much, Day 5. It is an honor to be associated with such pioneers and ulhas. You've done an amazing job putting this together. I think with COVID affecting every corner of this earth, it is definitely something that we are going to have to continue adapting to. And this shows that we can adapt academically and scientifically, putting great minds together and continue to do great work. So applause to you and the other scientific members of this meeting. And again, it is quite a pleasure to be calling in from Dallas, Texas, and being a part of this. And hopefully one day, again, soon, we'll have the opportunity to come back out to India and continue advancing on physiologic pacing and fluoroless anatomic mapping, and being able to do all the things that we all love, and actually advancing healthcare in that way. But it is my pleasure to introduce Dr. Vijay Raman, who really doesn't need much introducing. If you do know the arenas of EP, and really specifically anatomic pacing and heart failure, he has numerous publications. He started his career back at Albert Einstein with his training at Montefiore, and has been a full professor now at Geisinger for numerous years. Publications galore in this arena. Again, I am quite honored and humbled to be part of this panel as well. It is a great honor to introduce him, and I know that we're going to be learning a lot about these topics going forward, and hopefully we can open the doors to further collaboration from every part of the earth, which is exciting me as well. Then we'll start the first section off talking about anatomy and electrograms for his bundle and left bundle pacing. And Dr. Vijay Raman, if you'd like to take it from here, thank you again.
Thank you, Dale. Thank you, Ulhas, for the nice introduction. It's good to be back. So let me start my lecture. These are my disclosures.
Your screen, please. Share the screen.
Oh, I need to share. Okay. Can you see?
Yes.
Yes.
So let's start with the anatomy of the His bundle. I'm going to try to be short here. So you have His bundle that overlays the membranous septum, both on the atrial and ventricular aspect of the membranous septum. And so you can access the His bundle both on the atrial side or on the ventricular side. And there are quite a few anatomical variations. We'll go through some of them. And important things to understand is that where the lead is placed affects how the local electrograms are, whether the surrounding atrial myocardium, as you can see on the first segment of the slide, or the ventricular myocardium. So you can be higher up on the atrial side, well above the tricuspid annulus, or below the tricuspid annulus. So that will impact what your sensing is going to be, whether there's going to be far field atrial oversensing or ventricular undersensing. Those things are important. So what got me interested was when I had to do a pacemaker for a patient with complete heart block with a narrow QRS and able to place a lead in the His bundle and then identify and capture the His bundle and create a QRS morphology exactly similar to the native complex. So this was initially exciting, but as we went through, we were also able to identify that patients who have so-called infranodal AV block, here the PR interval is relatively normal, but has a wide right bundle branch block with a 2-to-1 conduction block. And intracardiac electrogram through the His bundle pacing lead, you can see the HV block. And what was surprising for me when I first had the first patient, this was one of my early cases, and we were able to completely correct the underlying HV block, even pacing at 150 beats per minute. We were having 1-to-1 conduction at relatively low output. So that opened the doors for us to explore His bundle pacing in a lot of clinical scenarios. So if we want to look at some of the anatomic variation, this is by no means a complete presentation. Kawashima's work on various courses of His bundle on the right side of the membranous septum is somewhat helpful in understanding the responses to His bundle pacing. So the so-called type 1 is the most common one, where the His bundle runs at the lower end of the membranous septum, but it's usually covered in a layer of myocardial sleeve. And so when you pace at this location, assuming that your lead is on the His bundle in all of these scenarios, you will have His bundle capture, but there would be minimal RV capture because of the sleeve of myocardial fascicle with fusion. And so when you do threshold testing, you'll find non-selective to selective His bundle pacing as you lower the output. So in this example, you can see a relatively narrow complex, the delta waves or pseudo delta waves initially, and at a lower output, you can see there is loss of myocardial capture and it becomes totally selective capture. So this is more common in the type 1 anatomy. In type 2 anatomy, the AV bundle or the His bundle is encompassed in myocardium. So it is intramyocardial. So invariably, there is a dense layer of ventricular myocardium on top of the His bundle. So when we are directly on the His bundle, again, you will have His bundle injury. You can also have myocardial injury, which is quite common in this scenario. So, which is a good sign because you will have good capture threshold for both. This is the second most common type. Again, you will get non-selective His bundle pacing for the most part. One caveat is that it's hard to have selective capture because the myocardial capture is going to be almost always there, similar to our left bundle branch pacing. And usually the RV capture threshold is going to be lower than the His bundle capture. And here's an example of that. So you have non-selective capture with a fairly wider delta wave, you can see. And as you come down on the output, you lose the His bundle capture and you have pure myocardial pacing. And you can also confirm that by looking at the retrograde conduction. the VA interval is prolonged as you lose the His bundle capture. And in the last example here is the type 3, which is the one we like it quite a bit, but also I'm nervous about when we implant leads in these patients. Here, the His bundle is without any dissection. It's very superficial. It's subendocardial. It's not covered by any myocardial sleeve. And so you can find huge His bundle signals here. And often you may have large current of injury. And quite often in these patients, you will cause bundle branch block, either right bundle branch block or sometimes even complete intrahisian block as you fix the lead into this His bundle. So you got to be gentle, careful, avoid too many turns in this location. So in this example, you can see a large His signals before implantation. And after you fix the lead, you can see the amount of injury current in there. And sometimes you may see injury current even before you fix the lead as the screw is just touching that region. And you will get very nice selective capture with a very low output in these patients. So all these responses are assuming that your lead is directly on the His bundle, not just adjacent to the His bundle. So we have put together a series of recommendation, but more importantly, to standardize definitions and what we ought to be looking at, what we should be calling accurately, whether it's selective or non-selective, and avoid terms like parahisian pacing, at least in the His bundle pacing literature. So this is a summary of, it's a very busy slide, but we'll try to go through this for the rest of the session here. So let's start with His bundle pacing in patients with normal His Purkinje conduction. So what do we define as selective His bundle pacing? So selective His bundle pacing, you only have His bundle capture. There is no myocardial capture. So if you look at stimulus to QRS interval, it'll be equal to His to QRS interval with an isoelectric interval in between. And there would be a discrete local ventricular electrogram in the His bundle pacing lead during pacing, suggesting that you're not capturing the local myocardium. And your pace QRS duration will be similar to the native QRS duration. And usually you have only one capture threshold, unless really at high outputs you will have non-selective capture. And so here's an example. HV interval is 40 milliseconds, QRS duration is 90 milliseconds, and pacing results in stimulus to QRS interval of 40 milliseconds, and the QRS is identical to the native complex. And in this example where the arrow is there, you see the local ventricular electrogram discrete from the pacing artifact, suggesting that it's not being captured by the stimulus. In non-selective His bundle pacing, usually at the onset of the stimulant, there is myocardial capture. How much of it is visible on a 12-lead lead? It varies depending on the density of the myocardium nearby. So the stimulus to QRS is usually 0 or less than His to QRS duration. And the local ventricular myocardial signal will be captured by the stimulus artifact. This is probably the most helpful in determining that this is selective or non-selective. And pace QRS duration usually is wider than the native QRS because of the amount of time it takes to capture the His and conduct to the ventricle, during which there is fusion of the local myocardium. And more importantly, you invariably will see two different capture threshold. There should be a His bundle capture and an RV capture. Occasionally, you may have both thresholds being almost identical, and you can use some electrophysiologic maneuvers to differentiate the two. So here is one example of where there is a native QRS of 80 milliseconds. Pacing at a slightly higher output, you have QRS duration of about 140 milliseconds, but 120 milliseconds here. And there is a significant delta waves. And as you go down on the output, you have non-selective capture with non-selective to right ventricular myocardial capture with a long VA interval. And another example would be where you go from non-selective to selective capture, depending on the type of the anatomy and how proximal to the His bundle you are, or you will see this response. Here you have a QRS duration of 140 milliseconds with non-selective capture. A lot of the initial activation is very slow activating myocardial pseudo-delta wave. And at a lower output, you have selective capture with narrow QRS complex. And the VA interval remains unchanged because the retrograde conduction is fastest with the His bundle capture. And this becomes a little bit more complex when you look at his bundle pacing in patients with His-Purkinje conduction disease, and whether you have complete or partial correction of the underlying conduction disease. And so start with selective His-bundle pacing with correction of His-Purkinje conduction disease, either it's a bundle branch block or complete HV block. The stimulus to QRS is either going to be equal to His to QRS or narrow in patient with longer HV intervals. Sometimes you might find that capturing the distal His would shorten the HV interval, so stimulus to QRS interval will be shorter. You still see the discrete local electrogram. And the pace QRS duration by definition is going to correct the underlying bundle branch block, so it should be significantly narrower than the native QRS. And again, you will have two capture thresholds, one where you have bundle branch block correction, and if you are proximal to the site of block, then you will have His capture without bundle branch correction. There's a scenario where you're distal to the site of conduction block, so you will have correction all the way to the end of threshold. So in this example, there's a wide right bundle branch block, and at 1.2 volts and above, there is complete correction of the right bundle branch block with the QRS duration of 100 milliseconds. And at a lower output, you have native right bundle branch block showing up. So this was all the way down to 0.5 volts. So you have two thresholds, and your whole goal is to program above the correction threshold during follow-up. That becomes critical by using 12-lead or multi-lead ECGs to confirm that. And here's another example of a left bundle branch block, 190 millisecond QRS, and selective capture with correction all the way down to 95 milliseconds, which is very, very helpful in patients with left bundle branch blocks and cardiomyopathy. And at a lower output, you have no correction. So again, this is one of the limitations of His-bundle pacing for CRT, is that very often the left bundle branch block is somewhat distal, so you're pacing proximal and the thresholds are somewhat high. And in patients with HV block, this is the so-called traditional intra-Hisian AV block. You have 2-to-1 AV block here, and it's a HV block, as you can see where the arrow is, and the QRS is completely narrow. We now know that many of the so-called infranodal or infra-Hisian blocks are all intra-Hisian. Vast majority of them are intra-Hisian. Even with right bundle, left bundle branch block, they can be corrected. Here, you can see that there is selective capture with correction and one-to-one capture. And even if you pace at higher output, at a faster rate, so you should be able to conduct. Otherwise, you shouldn't accept this position and look for something distal. And let's move on to non-selective His-bundle pacing with correction of His-Purkinje conduction disease, which is more common than selective capture because by definition it's an intra-Hisian block. So you want to be slightly more distal to correct, and often there's more ventricular myocardium there. So again, similarly, stimulus to QRS will be usually less than His to QRS, and you will have direct capture of the local ventricular electrogram, and pace QRS duration more often is narrower. Sometimes it can be identical even with correction, or maybe even wider, depending on how wide the underlying bundle branch block is. And you may be able to identify 3 different capture thresholds, one with correction, then without correction, then with RV capture, depending on the order in which it happens. We'll see some examples. So here's a patient with, again, a right bundle branch block, wide 160 millisecond QRS. So pacing at one higher output, you have complete correction. And sometimes it's hard to know, is it really true complete correction? But as you come down on output, you have another pattern here. So there's a partial right bundle branch block pattern. This would mean that you're capturing the left bundle and RV, but no capture of the right bundle branch. So there's a partial fusion correction. And at a lower output, you have only RV capture. So you have non-selective with correction and non-selective without correction of the right bundle, and then RV capture. Here's another example of another right bundle branch block. So complete correction, and then there is selective His-bundle pacing with complete correction, loss of RV capture, and then there is selective right bundle capture here. So we are actually distal to the site of block here, and we are able to capture the right bundle beyond the site of block. So that threshold is even lower. And occasionally you may find patients like this. And this would be ideal scenario, so where you get full correction at a low threshold. And now, what about partial correction? This makes it very challenging in patients undergoing CRT to know, have we achieved what we want to achieve? So you have a very wide left bundle branch block, and pacing at a higher output, you have some narrowing, but if you didn't have intracardiac electrogram, it would be very hard to appreciate that. So the QRS duration itself is still 180 milliseconds. That's fairly wide. But if you look at the QLV or his to LV timing, that is decreased by about 70 milliseconds. And that is a significant synchronization when masked by the RV fusion. And again, at a lower output, we can confirm that that's exactly what's happened because it converts to selective hispanal pacing with partial correction. So you have a 70 millisecond narrowing from 195 to 125 milliseconds. But without looking for these changes, you may look at this and say, it's not a good correction, let's move on. And this is selective hispanal pacing without correction. So you have to pay attention and not just discard when you have some kind of narrowing or changes in QRS morphology. Try to assign, understand. Sometimes it can be very complex. And even after all these years, sometimes I find it very difficult to interpret this partial correction with fusion. And here's a patient with complete HV block, right bundle branch block, escape rhythm, pacing at a higher output. There is correction and RV myocardial capture. And then at a lower output, you have selective capture off the patient with the complete HV block and capturing the left bundle alone. And you have right bundle branch block pattern with the narrow QRS here. And the goal is to find an output that would have the best QRS morphology, the maximum correction. And so that's important when you're trying to program. And how about patient without correction? Is it of any value? Sometimes it's helpful. Sometimes you know that it's not correctable, and then you have to choose alternative options. So similar criteria as we talked about. I'll just go to show the electrogram morphologies. Here's a right bundle branch block. Where it's helpful is that pacing here does not narrow the total QRS, but it has somewhat normalized morphology, albeit with a lot of slow fusion. And you can be sure whether it's only RV capture or is it fusion capture. But doing lower output, as you can see at 3 volt, you lose the RV capture here, and you see the selective capture with underlying right bundle branch block. So there was no correction at all here of the bundle branch block, so the QRS is still fairly wide. What we did in this particular patient was we used a pseudo fusion technique. So you paste the his and selectively capture the right bundle, selectively capture the his without correction, and then paste the RV at a delay from HV interval. And then you got finally a relatively narrow QRS of 100 milliseconds. So it's sometimes helpful. We can use the same technique in left bundle branch block, also left bundle branch pacing and allowing native conduction. So those are valuable lessons using electrophysiology to help. Here's another patient with a very wide right bundle, long HV interval, and it was hard to figure out, is this really correction or not? In this patient, you can see there is non-selective correction of the bundle branch pattern, but there is no real true correction of the right bundle branch block. This is something we didn't accept because it was a fairly wide QRS morphology. We don't know how much we could achieve in this patient who has a lot of intramyocardial conduction delay. But just as an example to understand and appreciate, just don't go by the QRS duration alone. Try to understand what is the underlying physiology for the particular pace complex. So we know that hispanal pacing, while probably most ideal in many scenarios, there are several limitations. High threshold, we continue to see. Hopefully some of this is improved with the newer tools that are available, and there are a lot of improvements coming along the pipeline. What bothers me at this point is there is about 10% of patients, there is unpredictable threshold increase during follow-up. The vast majority of them do well, but the need for lead revision at 5% is troublesome. And often you may have to accept smaller R waves or ventricular undersensing because of that, and maybe atrial oversensing, where you have more in the atrial side of the site. So that has led to a new revolution in terms of left bundle branch pacing. I'm going to talk a little bit about it in the interest of time. And then we know we have quite a few speakers following us to talk more on the left bundle branch pacing. The idea is that in many patients, left bundle branch pattern is a fairly wide network on the left ventricular subendocardium. But I wish all my patients had this kind of left bundle branch anatomy. So you stick it anywhere, you get a nice left bundle branch potential. But that's not the true. So you may have something like this. You may be in the middle here and not see a left bundle branch potential. But and some patients may have very thin fibers. Despite that, I think because the left bundle is so close, pacing anywhere here may get into the conduction system within 20 milliseconds. So you still have an advantage of being LV septal pacing, being able to synchronize the left ventricular activation in the vast majority of patients. In cardiomyopathy patient, that may be a little bit tricky, but at least in pacemaker population, this is probably true for most cases. Even if you're left septal, it may be adequate. In cardiomyopathy, I would strive harder to get a left bundle branch capture directly. So here's just a summary of various advantages. You can be a purist and go for his bundle pacing, and or more be practical and go for left bundle pacing because of the practical advantages. But I think we should still strive to get the best for the patient. And so we start with this bundle pacing and then move to left bundle branch pacing. Hopefully there will be better tools to get the best for all of our patients in the future. I'll just go with a few examples here. Patient with chronic left bundle branch block and intermittent high-grade AV block. As you can see, start with his bundle pacing. HV interval is long. In pacing at a relatively high output, I was able to correct the left bundle branch block. This was at 2.5 volt was a threshold for correction. And pacing at faster rates, I would only conduct 110 beats per minute. So we went on to get left bundle branch pacing. An important thing is during left bundle branch block, because it is blocked, there is no potential. But when there is conduction, and you will see potential. So either during a conducted beat or a premature beat that happens during implantation, you may be able to see the potential. Or if you do his pacing and correct the left bundle branch block, you will see a potential then show up on the left bundle electrode. So those are little tricks to look and convince yourself that you have left bundle branch capture. Alternatively, when you do threshold testing, especially unipolar testing, you have this right bundle branch block pattern suggestive of left septal capture. And at lower output, you see the change in morphology that shows you that it is a selective left bundle branch capture. So when you see this transition from non-selective to selective, that gives you confidence that you are having a conduction system capture. And very commonly, this will happen very close to threshold. So it's important to pay attention for subtle changes in QRS morphology. And these are all gained up, so you may have to very carefully look for them. And again, these patterns are quite variable depending on where you're pacing, where's the level of block in the conduction system, and whether you're proximal or distal, anterior or posterior. And when the addition of the ring electrode, you have anodal capture. So at a higher output, you have the capture from the ring electrode, and that somewhat nullifies the effect of the right bundle branch block. And again, at a lower output, you have the same transition to non-selective left bundle capture to selective left bundle capture. I find it even harder to use. I'm not displaying any set criteria for non-selective selective because it is more and more challenging, and I see so many different patterns. So hopefully we'll come up with a unified description of this. So another patient with a 2-to-1 AV block, infranodal block. So his bundle pacing, you can see pace QRS duration 136 milliseconds, RV capture at a lower output. And this is the final his pacing electrogram, very nice and narrow complex. And what will be in a left bundle branch pacing in the same patient? So some patient you can get a really good morphology. Here is anodal capture with bipolar pacing. QRS looks almost similar to what we had with the his bundle pacing. This is the final pace QRS morphology. So in many patients, his bundle and left bundle can be identical in terms of QRS morphology.
I'm extremely sorry for the interruption, sir. 2 minutes of the screen time left. Thank you so much.
Thank you. So that makes it challenging to figure out whether the pace QRS is his bundle or left bundle. I used to describe them routinely as his or left bundle. Now I just call it conduction system capture when I can be sure. I'll just skip this and go to the questions that Ulhas already posted online, I think. So here is a 75-year-old man with complete heart block, underwent permanent his bundle pacing, came in with some dizzy spells. And I'm going to show you the EKG, decide whether this ventricular undersensing, oversensing, non-capture, or is just normal functioning. Sorry for the bad slide. You see relatively narrowish looking complex and a lot of fusion on the non-selected capture. So there is a atrial pacing and followed by ventricular pacing. Here there is atrial pacing with atrial capture, no ventricular pacing output, suggesting that either there is some kind of oversensing that inhibits the ventricular pacing output. And so that was the reason why there is no pacing output to capture the conduction system. So we were able to adjust the sensitivity to correct the problem. Here's another common scenario that you might find because patient with AFib, sinus node and AV nodal disease, young woman, some kind of congenital problem, channelopathy likely, DDD pacer, and comes in with palpitation. And this is the EKG that was seen. So I was disturbed that why is there is no his bundle pacing here, even though she had excellent his bundle capture in the past, and fairly ugly looking white QRS morphology, and some group readings suggesting upper rate behavior. So why do we have white QRS? Is it loss of his bundle capture, or is it incorrect programming of pacing output, or is it just parahisian RV capture only? So the scenario could be any of the above. And so threshold testing here at 4 volts, you have nice non-selective his capture, and around 2.25 to 2 volts, there is loss of his capture and there's only RV capture. So the his capture threshold is 2.25. And the patient was programmed at 2 volts because the RV capture threshold was 0.5 in this patient. So it looks like somebody changed the final program output without paying attention. So once we adjusted the output to 3 volts, then you have perfectly normal looking non-selective his bundle pacing. So it's important to know how to program and pay attention to the QRS morphology during threshold testing. Lastly, just want to emphasize, because there's a lot of confusion often. I know we discussed about a lot of different patterns. You can change from non-selective his bundle pacing with correction of bundle branch block to no correction, non-selective bundle branch pacing without correction to right ventricular pacing. Can we have selective his bundle pacing with bundle branch correction to non-selective his bundle pacing without bundle branch correction? So which of the transition is not a possibility? So you can never go from selective to non-selective. You can always go from a non-selective to selective or non-selective to RV, but you cannot go from selective to non-selective, because if you have selective at a higher output, you cannot have non-selective at a lower output. So that's just a point that I want to emphasize. And we've seen this slide earlier. So I want to just complete my talk in time. And thank you very much.
Thank you so much for that amazing talk and review of the anatomy. I have so many questions. I'm sure many people do. We could do a whole day or a whole week on this session alone, and I think in the future we probably will as this field continues to expand. But again, amazing talk. I wanted to lead with a few of my questions. When you program your non-selective or selective thresholds, how do you go about it? And I guess I'm getting at the point that your study, as well as other studies in the past, have potentially shown that non-selective versus selective may be identical or similar in terms of long-term morbidity and mortality. So do you feel that just putting the threshold much above that threshold where that transition occurs is good, so that you can at least get non-selective capture, or do you try to really get it in between the two?
So at the time of implant, we generally, at least in my lab, is that our goal is to get a good His capture threshold, whether it's selective or non-selective. Generally doesn't matter because a lot of it is dictated by the anatomy. So if you go for selective only, then you are troubled by the fact that there would be oversensing or undersensing issues. Unless it's in a dedicated port where sensing is not essential, then I would go for a selective capture if that's something I desire. That's more of in an aesthetical sense. For practical purpose, I would accept a non-selective. But the goal is to have a safety margin of at least 1 volt above the His capture threshold. So let's say you have a non-selective capture at 3 volt and His capture is at 1 volt. Now we have room to program a selective capture at 2.5 volt. But if you have non-selective at 2 and selective at 1.5, I wouldn't waste my time trying to get selective and program 1.75 because there's always this concern of will the threshold rise during follow-up, will it fall? So safety first, and I would try to have at least a minimum of 1 volt above, and I would follow them closely to make sure that threshold doesn't increase, so we're programming appropriately for those patients.
That's great. Yes, I know that comes up a lot, and I get that same question. But I think I think safety matters. A lot of these patients obviously have severe conduction abnormalities, and having that safety margin does matter. In my own experience, I think about, I'd say 10 to 15% seem to also have increases in threshold over time, and obviously had a few where we could try to get cute with that selective capture, and they came back completely not capturing, and that was obviously more of a clinical issue. So I completely agree, and I like that answer. Also, I guess with trainees sometimes, and even with our experiences, how do you go about the number of times you attempt with the difficult anatomy to go for the His capture, as I feel that there's often injury as you continue to screw it in, take it out, screw it in. You're obviously causing some damage there. Injury currents start to affect how you are capturing tissue. I guess my ultimate question there is, when is enough, and when do you decide to move on to another approach, whether that's typical LV, CRT implantation versus LVVB or whatnot?
So that's a loaded question, but I'll try to answer. But it's an important topic because especially with training, and I do have my own trainee right now. So the trainees, at least early in their experience, get 1 attempt. The more important is for them to able to handle the sheath and the catheter to locate the His bundle, and then learn the art of fixing the lead. But for practical purposes, the way I do it is, I've evolved over a period of time. So I find the His bundle. Once I locate the His and I like the signal, then I try to make 1 or 2 rotations on the lead. I try not to do full fixation. So a couple of rotations, and then get my sheath very close to the tip electrode, and then check a threshold. And I want to have a threshold less than 2 volt before full fixation, because when you have your sheath opposed to the wall, then that gives you enough pressure to get a acceptable threshold, which will almost be close enough to the final threshold without fixation. So if I have threshold higher than 2, then I don't waste time trying to, for the points that you mentioned, because you can cause injury, edema, makes it challenging to further attempt another site. So I try to limit the number of fixation attempts that I would do. So my attempts will be locate the His, 1 or 2 rotation, get good apposition with the sheath. If the threshold is not good, remove the lead, try a different site. I would do as many times as possible as necessary. But more importantly, in a bundle branch block for CRT indication, I would pace at high output to see if I'm correcting. And within 3 or 4 attempts, if I see that I'm not getting an acceptable threshold for left bundle branch block correction, now we have the left bundle pacing, which is pretty valuable in this scenario. So I move quickly at that point, knowing that I have bundle branch correction, and left bundle pacing would be very ideal for those patients. So I move on to that.
Great answer. I'll open it up to others now for any questions.
Yeah.
So, Dr. Vijay Raman, thanks again for a wonderful talk again, and thanks for teaching all of us and across the world how to do his bundle pacing. So, before I take the questions from the audience, one question from my side is, do you have any predictors in patients who have one-to-one AV conduction with bundle branch block and with those with complete AV block prior to implantation that will predict that you will get good correction of bundle branch block during his bundle pacing?
So there are two separate questions, right? One for when you're implanting for bundle branch block, especially left bundle branch block
Yes.
or CRT. Again, like any hyspophageal conduction disease patients, you have to pace at a faster rates. And that number, I usually try to pace at least up to 140 beats per minute to make sure that you have complete correction. And at least I try to pace at 1 volt above what your correction threshold was at 60 or 70 beats per minute that you tried. You need to have those corrections. So if you don't have the similar degree of correction at a faster rates, then I may be I worry that I may be too proximal to the side of block. And because we want to achieve long-term correction, so that is important. So pacing at a higher output, closer to threshold to ensure that you have persistent correction. So that is important. Not only do we have a problem of late rise in threshold in some of these patients, but if you don't assess this properly at implant, then you will be unhappy and dissatisfied, both the physician and the patient. So that is important for me. And the same thing holds true for any infranodal AV block patients. So it's absolute must that you pace at a faster rates, because you can be fooled pacing at a slower rate, and then you may have correction, but not at faster rates because there is some conduction delay because you're proximal to the side of block. And my approach has evolved since the availability of left bundle pacing, and my ability of left bundle pacing has improved. So now if I have infranodal HV block, I don't try his bundle pacing. I do his bundle mapping, but I go straight to left bundle branch pacing for infranodal pacemaker AV node block population. For CRT, I still think his bundle pacing is better if I can get threshold below 1.5 volts, even for left bundle branch block. If I'm not able to meet that goal, then I would go to left bundle branch pacing, which happens probably close to 70-80% of the time at this point. So we are moving more and more towards left bundle pacing. And I'm trying to do distal deep septal his bundle pacing, trying to get to the distal his bundle, but place it deeper. That's a challenge. I think it's limited by the tools. Hopefully we'll get there at some point in the future.
Deep comments,
None from my side. Thank you, Dr. Fogel, as usual, and for especially as Dr. Kartik had pointed out, in propagating this and teaching the world how to perform his bundle pacing and things. Moving on to questions from our audience. One of the questions from Dr. Yash.
Yes, you know what? We could see so many questions here, but I think the upcoming speakers are going to be addressing that. So this session, basically anatomy and the electrograms, and a fantastic question from Dr. Yash. You can read it up. It is something to do with the intrahesian. Why, intrahesian? Why don't we see A followed by H, and there's a block, and there is a V, and then there's a before H. This kind of a pattern, intrahesian block, where it should have been seen. Why don't we see that? I think Pugul, you may be seeing the questions there, or no?
No.
Okay, so Yash is asking, why is that if the majority are intrahesian blocks, in many cases, we are unable to show two His signals, one with the A and the other with the QRS? Why don't we see this?
Yeah, so I think I see that probably about 10 to 15% of patients with HV block, that we see that intrahesian, the split His that we talk about. Is that right? That's how traditionally we were taught that intrahesian block is from when you see that you have narrow complex and you have a split His. And there's not a lot of explanation, but my own theory is that when you have split His, it's a very narrow zone of conduction block, and and you have to have equal amount of delay on both fascicles at that site. So it's a very narrow area of conduction delay. So that happens with intra-ACN block. So most complete HV block is this little bit of, what should I say, little dysynchronous delays in both the fascicles, and it's a slightly wider area of disease. But we've had many patients with infranodal, intra-HCN, so-called HV block, but no split His, but you can get to the distal His bundle region and be able to correct completely. Where we have a lot more evidence now is that in many of these patients with HV block, when we go to the left bundle region, invariably we see potentials, and we can confirm that the conduction block is between the two, between the proximal His and the proximal left bundle. So it's higher up, but just that we are not able to get to that distal part of the His bundle from the RV membranous septum. And I would say that 90+% of these patients are all intra-HCN block, but just a little more wider disease than what you see in traditional so-called intra-HCN block with split His potentials.
Okay, thank you very, very much, Dr. Dale. Kartikeya, Deep, I know you have been great moderators for the session today. The pioneer of His bundle pacing, who started off this physiological pacing session today. Thank you, Pugal. We look forward to your continuous patronage, your continuous support. India, is learning so much from you. So we move on to the next session.
Thank you, Mohan.
Well, Dr. Shanmuga Sundaram, the most inspired person with respect to the physiological pacing from Pugal, from Parikshit, and everybody. And we are so very proud to have Shanmuga Sundaram in our field of electrophysiology, who now is almost shoulder to shoulder to the pioneers like Pugal and Parikshit. And he starts, recently also he has proctored online left bundle pacing. So I think his ability, his understanding of the left bundle pacing is so enormous that the world is looking towards him for proctoring and knowledge from him. And it's such a pride for the Cardiological Society of India and the Chennai chapter that he again addresses with all experts like Pugal and Parikshit. And then I think it's a privilege for us to learn from him, typically the left bundle pacing. Over to Dr. Shanmuga Sundaram, and he's going to be introduced by the Vice President of Indian Heart Rhythm Society. Privileged to have him here on the screen today, Dr. Ajay Nayak, and he's going to be ably assisted by Jitendra Makkad, another accomplished electrophysiologist and also known for his physiological pacing work. Makkad, welcome. And Dr. Venkateshan, interventional cardiologist from Chennai City, great academician. So it's a privilege to have all of you. And over to Dr. Ajay.
Thank you, Dr. Ulhas, and compliments for putting together this fantastic program, the Cardiac Rhythm Council. It's my pleasure to welcome my co-panelists, Dr. Makkad and Dr. Venkateshan. And it's a particular pleasure to introduce Dr. Shanmuga Sundaram. He's been the stalwart in his bundle, left bundle pacing for the country. Dr. SMS, as we fondly call him, has trained from Sri Chitra and has done his fellowship from St. Luke's Medical Center at Milwaukee. He is accomplished in electrophysiology, has done a lot of work in pediatric arrhythmias and implantations, but particularly his particular work in the His bundle, left bundle pacing has been tremendous. He's been not only doing in person, but also online proctoring for the cases. So, Dr. SMS, why don't you take over and present your left bundle cases?
Thank you, sir. Thank you very much. I would like to thank Ulhas sir again for giving me this golden opportunity to share my cases. Can I share my screen? Is it visible, sir?
Go on to the slide.
Yes, go ahead.
Yeah. Thank you, sir. It's my pleasure to be here to share two of my important cases of left bundle branch pacing. For want of time, I would like to go into the topic immediately. So what is the need for left bundle branch pacing? Like Pugalenji sir was discussing about the benefits of H bundle pacing, but there are certain limitations which made left bundle branch pacing to be kept as a backup tool for doing a physiological pacing. We know that H bundle pacing is going to have a narrow target, and lead dislodgement and lead revision are going to be there probably in 5 to 10% of the cases. And we know that in up to 10% of the cases, there will be a late rise in thresholds. Ultimately, we have to program the battery at a higher output, so which will ultimately lead in early battery depletion. And sometimes, like Vijayaram sir was telling, if the disease is quite distal, it will be difficult to approach the distal bundle. So in those cases, probably we may end up in narrowing the QRS. So these are all the problems with this bundle, which can be overcome by doing left bundle branch pacing. I'm not going to go into the criteria for doing left bundle branch pacing because we can easily get it from all the review articles which are available. But one thing I would like to stress here is QRS morphology alone is not going to predict, like sir was telling, sometimes you can get even a QRS which may mimic the normal QRS or the Hismal-based QRS in patients with the left bundle branch pacing. So beyond that, you should be able to demonstrate the left bundle potential and peak, short and constant peak LVAT, and this non-selective to selective capture at low capture threshold output. Of course, if there is any difficulty, probably you can do programmed stimulation protocol to look for this refractory period of the left bundle. Briefly, the procedure. So usually what we will do is we'll keep a catheter from the groin to have the fluoroscopic landmark of the His bundle, and keep a catheter in the right ventricle to provide the backup pacing. So this would be the rough image of the cardiac conduction system. So if you have your His bundle catheter at the dislection of the his signals, then you have to draw an imaginary line connecting the distal His bundle to the RV apex. What you have to target is the initial 1.5 centimeters. So you have to target this zone. Suppose if you are going more proximal, closer to the His bundle catheter, you may end up in injuring the coronary artery because the septal branches may come up there. So ultimately, there is a chance that you may damage the coronary arteries. Suppose if you go straight in line with your quadripolar His bundle catheter, you may end up injuring the right bundle, producing iatrogenic complete heart block. So you have to keep your sheath and the lead just below the His bundle region, and you have to target that initial 1 to 1.5 centimeter, not closer to the His bundle. So this particular topic per se, so this first case is about LBBB correction by left bundle branch pacing. This is about a 36-year-old female who was referred for cardiac desynchronization therapy. A typical case of non-ischemic dilated cardiomyopathy, LV dimension of around 62 millimeter with an EF of 28%. ECG showed a complete LBBB with a QRS of 150 milliseconds. Coronary angiogram done showed a normal coronaries. So as a policy, we always suggest an option of physiological pacing to those patients, especially with the non-ischemic DCM, and after getting the informed consent, left bundle branch pacing was performed. So this was a baseline ECG. The QRS duration was roughly around 150 milliseconds with an EF of 30%. So D always place a His bundle catheter from the groin to know what is happening in the His bundle region, and there are a lot of important things which you can monitor while doing the procedure. So it's better to have a fluoroscopic landmark while doing the procedure. So many times we tend to notice that the His bundle HV interval is going to be prolonged in all patients with a non-ischemic DCM. And if it is prolonged, like if it is more than 70 milliseconds or 80 milliseconds, ultimately you will end up in getting a good final QRS. That will tell you that it's more of a conduction system disease related problem, and the chance of myopathy is going to be less, and the chance of correcting the LBBB is going to be more. So this particular lady had an HV interval of around close to 60 milliseconds, and we could capture the left bundle without any difficulty. We could demonstrate this non-selective to selective capture of the left bundle. You can see the local ventricular electrograms. This is the pacing spike of the left bundle lead. This is the local electrogram. So once you reduce the output from 0.6 volt to 0.5 volt, you can see the splitting of the local ventricular electrogram from the pacing artifact, and you could also notice the subtle changes in the QRS morphology. This confirms that your lead is on the left bundle, and there is a transition from non-selective to selective capture. We could also demonstrate this programmed deep septal stimulation. This particular protocol it's very valuable in those patients where it is very difficult for us to show the other capture criteria. So here you can gradually reduce the S2 interval from 300 milliseconds, 290 milliseconds, 280 milliseconds, and see the morphology of the QRS. So see here at 280 milliseconds, you can see a QR pattern, the LVAT is rapid. So once they reduce the S2 from 280 to 270, you can see a typical change in morphology, probably some sort of loss in R wave, and you can see the prolongation of the LVH. So this confirmed that, so here it is a non-selective capture of left bundle with the local myocardium, and here it's only the capture of the local myocardium. So at 260 milliseconds, there is a complete loss of capture. So this is a left bundle refractory period, this is local myocardial refractory period, and this is the local myocardial refractory period. So this will again confirm that you are right on the top of the cardiac conduction system. So the pace QRS, after adjusting the AB output, AB delay and the output was around 99 milliseconds, could get a good QRS as good as we can get it from these bundle pacing. So this was a final lead position, which was, though there was a slight reduction in the atrial root, we accepted that and you discharged the patient. And at the second month follow-up, the EF improved to 40%. Everyone was happy. The patient was symptomatically better. But at the third month, there was a reappearance of symptom. So remember, those patients who had a typical non-ischemic cardiomyopathies, when you're doing a conduction system pacing and you have narrowed down the QRS, once the EF starts improving, there will not be any turn back. So only thing what you can see is a gradual increase in the ejection fraction and gradual reduction in the heart failure symptoms. But once you see these sort of things, the reappearance of the symptoms, you have to be very careful in looking for lead-related issues. So this particular patient, the ECG showed a complete LVBB with sinus tachycardia. Interrogation showed complete loss of both atrial and left bundle capture. So this is the fluoro. So I immediately took the patient to the fluoroscopy, and this was the fluoro. So both the atrial as well as the ventricular lead or the left bundle lead got dislodged. So ultimately, we had to redo the procedure. So opened the pocket, extracted the left bundle lead, extracted the atrial lead, and implanted a new left bundle lead. I didn't go for a conventional CRT here because my previous result was very, very good. So I opted for redoing the procedure. New left bundle lead was implanted, and again, a beautiful QRS of 90 milliseconds. The patient responded well, and at the end of 2-month follow-up, her EF improved to almost 55%, and we have reduced the heart failure medication. This is the final fluoroscopic view. So what we did was we just analyzed the previous fluoroscopic image. So what is the reason for the dislodgement? I know that the left bundle loop was a little less, but that could have dislodged only the left bundle lead, not the atrial lead also. So when we analyze this lead subclavian angle, so the initial puncture I took was a little oblique. So I usually create a pocket and then I usually take the puncture. So this oblique puncture might have created an oblique angle since it was going through the tissues. After taking the puncture and after fixing the lead to the tissues, I was not able to correct it in a straighter way. So this angle of 90 degree was maintained. And what happened, probably the patient might have manipulated the pockets, or some sort of fiddler would have aggravated the thing here, and this would have probably pulled down both atrial as well as the ventricular lead. So if it would have been a pure left bundle lead dislodgement, probably it might be related to some lead-related, probably the property of the lead and the relation to the left bundle, this ventricular myocardium. But it is actually a dislodgement of both the atrial and the ventricular lead. So this made us to think that probably this angulation was the problem. So second time what I did was I removed both the atrial and the ventricular lead. I took a new puncture and I made sure that this will be in line with the pulse generator and the pocket. So next time I could give a good adequate loop, and the PG, the left bundle lead stayed. So this was the echo at the end of 3 months. You can see the EF has improved well, and there is a synchronized contraction of the ventricle. So doing a physiological pacing is much easier in left bundle pacing. But only thing is that you have to take this smaller thing, which might create a problem during follow-up. My second case is another CRT by left bundle branch pacing. This is regarding a young male patient with a right bundle branch block, QRS duration of 156 milliseconds, again with a normal coronaries and an EF of 30%. So this was his intracardiac electrogram. So I thought of attempting his bundle pacing first, because doing RBBB correction, I think his bundle will be better rather than doing left bundle pacing, because in left bundle pacing, again, we are going to create a right bundle branch block delay. So we tried this pacing, and you can see here that the local HV from the groin electric catheter was around 65 milliseconds, and the lead electrode showed a HV interval of 45 milliseconds. This means that probably we have crossed the site of block, and we could produce a QRS of around 170 milliseconds. But the only issue was the lead threshold was very high. The right bundle branch correction threshold was close to 3 volts at 1 milliseconds pulse width, which actually we could not accept because ultimately we'll end up in draining the battery. So we went down and screwed the lead in the left bundle area so we could get a juicy left bundle potential, and we could narrow down the QRS, and with the help of anodal capture, we could even mask that significant RBBB delay, which usually occurs in left bundle branch spacing. So this is the final lead position, and this is the final ECG. We could obtain a QRS duration of close to 100 milliseconds, and the echo showed a definite improvement in LV ejection fraction. But this took a little long time. So usually this LVDB correction by physiological pacing, the EF improvement occurs within probably 1 to 1.5 months. But this particular RBBB, even in other patients where RBBB correction was done by physiological pacing, it took almost 2 to 3 months for the EF to improve. Here you can see a significant reduction in LV and diastolic diameter, significant reduction in LV systolic contraction, and there's not much of synchronous dysynchrony in the septum and lateral wall, and you could see a definite improvement in EF. So in patients with the right bundle branch block, we know that they are poor candidate for cardiac resynchronization therapy by BiWave devices. So probably physiological pacing would be better. So either a his bundle pacing or a left bundle pacing. But in patients with RBBB, I think we should attempt his bundle pacing first before going for left bundle, because his bundle will be probably a better form of, will produce probably a better synchronized contraction as compared to left bundle branch pacing. But a word of caution, we know that left bundle branch pacing first procedure was done in 2017, so we don't have any long-term data available. At the maximum, we have data for just 3 years, and this lead is not meant for deep septal pacing. So data regarding the safety of this lead is still awaited. So we have to keep in mind these potential complications, late lead dislodgement to the LV. In fact, this was reported recently, and we had a case of ST elevation MI in a patient who had undergone left bundle branch pacing. And again, there's a big question mark regarding the data on lead extraction. Pugalenji sir has recently published a lead which was extracted after a year. But yeah, we need long-term data regarding the safety factor of this 3830 lead. And before that, probably it is better to keep it as a backup tool rather than keep it as a straight-away tool for doing a cardiac resynchronization therapy. Thank you. Regarding the questions, there are 3 questions which was given by Ullas sir. So this left bundle branch pacing is considered superior to his bundle branch pacing. So for me, I think I don't know the real answer because still we don't have evidence supporting left bundle branch pacing, but we know that there are a lot of limitations with his bundle, which can easily be overcome by left bundle branch pacing, but the safety data is still awaited. Left bundle branch pacing drains battery more than his bundle. No, this is not true. We know that his bundle, we usually keep the pulse width at 1 milliseconds and output probably in the range of 3 or 4 volt. But a left bundle branch pacing, I tend to keep the output at 1.5 volt at 0.5 milliseconds pulse width. So that is going to conserve the battery. Of course, lead stability is going to be better with left bundle branch pacing. The lead dislodgement rate is very, very minimal in patients who are undergoing left bundle branch pacing as compared to his bundle pacing. Thank you, sir.
Thanks, SMS. 2 excellent cases that you've shown. One with left bundle and other with the right bundle branch block in cardiomyopathy. One question I had is, this is a conceptual question.
Yes, sir.
When you're dealing with dilated hearts, up to what point of LV size do you think electrical correction with left bundle is going to help versus what we think is a LV lead on the lateral aspect and additional mechanical contraction that is provided locally? So what do you think is does the size of LV matter?
Yeah, the size of LV matters in terms of the natural history of the disease. Obviously, the larger the size of LV, probably they are in the later part of the natural history. So ultimately, their response to either a conventional CRT or physiological pacing is going to be less as compared to those with a lesser dimension. In fact, what we have analyzed is whenever the LV is less than 60 millimeter, the diastolic diameter is less than 60 millimeter, they usually respond in a much better way, and especially in females where the LV diameter is going to be less than 60 millimeter, the response is going to be very, very good, and they tend to have normalization of LV ejection fraction by the end of 1 to 1.5 months. But in those patients who have dilated LV, like beyond 70, beyond 80 millimeter, we have to keep an option of CS pacing as a backup. We cannot simply correct by doing, many times we may fail in doing a complete correction either by his bundle pacing or left bundle pacing. So we have to have a backup of CS lead whenever the LV dimension is going to be more than 70 millimeter. But I've done a case with the LV dimension of more than 80 millimeter for a couple of cases where still left bundle could narrow down the QRS to close to 120 milliseconds, and still the patient showed improvement in the LV ejection fraction. But definitely normalization of LV ejection fraction cannot occur if the LV is significantly dilated. In fact, there were a couple of studies from the Neolith group, I think Neolith 1 and Neolith 2. So both they have shown that in patients with left bundle branch block mediated cardiomyopathy, if you're going to do the CRT by conventional BIV device, they are going to have a much better response if you're going to intervene them within 9 months rather than intervening them beyond 9 months of diagnosis of LVP. So the earlier the better. The later probably we are allowing the disease to progress, and we are allowing the myocardium to go for some sort of interstitial fibrosis where the response is going to be suboptimal.
Yeah, thanks. There are a couple of very interesting questions in the chat box. I'll quickly go through them, and I'll invite Dr. Jitendra and Dr. Venkatesan to jump in anytime. So first question from Dr. Justin Paul. Can you help us understand the mechanism of correction of right bundle branch block with left bundle pacing?
Yeah, so that's a tricky question. In fact, so we are going to create a right bundle branch block delay pattern by capturing the left bundle. So only thing which we have to see is whether the patient has some associated conduction system. This is distally. So in the case which I have shown, the HV interval was prolonged. It was 65 milliseconds. A simple RBBV definitely will not explain the prolongation of the HV interval. So he might be having additional prolongation, additional distally, maybe in the left bundle also. And when you see that echo, the patient had typical dysynchronous contraction of the septum. So probably we may have to choose the cases while for doing a left bundle branch pacing in a DCM RBBP cases. If there is a dilated LV, if there is a prolonged HV, if there is a dysynchronous contraction, probably you may do some justification by reducing the LVAT, because by pacing the left bundle, you are going to reduce the LVAT to less than 70 milliseconds or 80 milliseconds. So if you are going to get that rapid left ventricular activation time of probably less than 70 milliseconds, that means that you are going to have a good synchronized contraction of your left ventricle at least. So that might produce some sort of improvement in the LV ejection fraction. So I'm not sure whether our RBBPs will be corrected and improve by doing a left bundle branch pacing, but at least in those segment of patients where there is an LV dilatation, where there is a dysynchronous contraction of the left ventricle, and where there is a significant prolongation of the HV interval. In fact, this prolongation of HV interval is very important, because even in those patients who had underlying left bundle branch block, if there is a prolongation of HV interval, the chance for narrowing down the QRS to probably less than 100 milliseconds will be much better as compared to those patients whose HV interval was less than 60 milliseconds. So that will just tell us that there is some sort of conduction system problem. So doing a conduction system pacing is going to solve the problem.
Yeah, SMS, there is another question which is dealing with the same issue. Dr. Saktivel is asking, if septum is thin or anodal capture threshold is high, how will you correct the right bundle branch block with the left bundle pacing?
Yeah, so if there is, in fact, anodal capture will help us in probably 20 to 30% of the population. In remaining patients, if you have a native AV nodal conduction, like happened in those patients with the DCM, you can always utilize this native AV nodal conduction. You can program the AV delay to probably 90 to 100 milliseconds rather than 70 to 80 milliseconds. So that will allow the AV node to take care of the right ventricle. Your left bundle lead is going to take care of the left ventricle. So that is one good way of correcting our created right bundle branch block delay. But in a couple of cases where I could not correct this RBB delay by either an anodal capture or by allowing the native AV nodal fusion, I had an option of putting an additional lead in the RV septum. So one was a CRT where the RV lead was there. It was actually a poor CS anatomy, so the RV lead was this lead was implanted. Left bundle lead was implanted. So we have an RV lead in situ, RV septal lead in situ. So both can be fused together to mask the RV delay. So another was an RBBB AF fast ventricular rate, severe LV dysfunction, heart failure. So I updated the AV node, paced the left bundle, produced a significant right bundle branch delay with a QRS duration of 130 milliseconds. So since I had opted for a dual chamber pacemaker, I put the additional lead in the RV septum, fused it together, I could narrow down the QRS to 110 milliseconds. So that is a third way, probably another way of correcting this right bundle branch block.
I have a question, Dr. Shanmugam Sundaram.
Yes.
So it's a very good presentation of these procedures. One thing is, in conceptually, when you say LBB pacing, is it a truly a physiological pacing? What about the interventricular synchrony? How good it's interventricular synchrony? After all, you are pacing asymmetrically from the left side of the septum. And what is your comment on that? One question. The other thing is, when the indication for his bundle pacing and left bundle pacing for sinus node dysfunction. The best mode for physiological sinus node dysfunction is atrial based pacing, which is already happening in DDD with the AA mode. So will you really advise his bundle pacing or left bundle pacing for sinus node dysfunction with the intact AV conduction?
Yeah. So regarding your first question, sir, actually, truly speaking, the most physiological form of pacing is going to be his bundle pacing, because there you will have simultaneous activation of both right bundle and left bundle. In fact, by doing left bundle match pacing, we are theoretically creating interventricular dysynchrony, because your RV and LV is going to have a dysynchronous contraction. Of course, that dysynchronous contraction is going to be there, but in those patients with the native AV nodal conduction, those patients where the septum is thick and your anode will be buried inside the septum, you can always utilize the option of anodal capture as well as a native AV nodal conduction to correct the RBB delay. So we make every single attempt to correct the right bundle branch block delay, either by allowing the native AV nodal fusion or by allowing the anode to capture. In fact, in some patients with poor AV nodal conduction, like in complete heart block, or those patients where the septum is not great, you might end up in creating a right bundle block delay, but still your left ventricle is going to have a synchronous contraction. That small minimal interventricular dysynchrony and its long-term clinical significance at present is not known, but at least as far as the right ventricle is concerned, probably we may not face any problem on the long run. And regarding the second question, in sick sinus syndrome, of course, sick sinus syndrome, it's purely an atrial-based pacemaker alone will suffice in many patients. In fact, what we usually do is pace the atrium at probably 130, 140 rate. If there is no AV venky backing, we'll accept that and stool a lead and come back. But we know that in elderly patients, at least 1% chance of developing an additional AV nodal problem per year in those patients who are more than 50 or 60 years of age. In fact, I had a patient where last year there was a sick sinus syndrome with an AV a PR interval of 160 milliseconds. On table, the atrial venky backing occurred at 130 beats per minute. But ultimately, he had a gradual increase in the ventricular pacing requirement. And fortunately, today he came for a review. He was a fully dependent patient now in terms of ventricular pacing also. So he had no native AV nodal conduction. So we know that still there is a significant proportion of patients, at least in the elderly population, where there is a chance for development of AV nodal conduction problem. So I think still, if you are going for a dual chamber pacemaker, instead of putting the lead in the right ventricle, we can secure the lead in either in the his bundle or the left bundle.
Ullas, we are going in unknown frontier. So if you need to stop anytime, just let us know, or whether we can squeeze in another question.
There's an expert, from India, Vanita. Vanita, who is so very passionate about this whole science, has a relevant question. It is something to do with the septal pacing. I hope you also are able to read that. Shanmugasundaram, I will read that question to you from Vanita. And that is relevant. And she's asking you, the septal pacing, had it been ever a concern to you in those patients with ischemic cardiomyopathy?
Yeah, ischemic cardiomyopathy, it will be a little challenging to do, especially if the septum is cut proximally. Your lead will just not go deep into the septum. So it will be a challenging task to do a deep septal pacing in those patients with ischemic cardiomyopathy. But still, in fact, in our study, which we published it, almost 40% of the patient had associated coronary artery disease. So if your proximal septum is scar-free, probably even we can get an MRI done if it is feasible to see whether there is a scar in the proximal septum, in that initial 1 to 1.5 centimeter below the tricuspid valve region. So if that area is disease-free, then probably we can still go for it. But in those patients with a significantly scarred septum, ultimately we will not be able to place the lead deep to capture the left bundle. So in that cases, probably we can opt for a his bundle with the CS lead or a distal RV septal lead with the CS lead if it is not working.
Thank you. And one last comment from Jitendra Makkad, if he is around.
I think Jitendra is not able to join in because of network issue. I'll ask a very practical question, SMS. If we have to deploy a lead and take it out because of suboptimal parameters, deploy it again at another place, invariably, I have seen I end up with doing a biopsy of the conduction system and maybe a few other tissue. And do you happen to damage the screw in any way?
Yes, sir. This damage to the screw occurs whenever it gets caught in the tricuspid leaflet or in the cardiac. So many times, if it goes smoothly into the myocardium, you can just pull it out, take out the tissues, and you can redo the procedure with the same lead. But if it's getting caught in the tricuspid leaflet, especially if you are trying area closer to the tricuspid valve, there is a high chance that the septal tricuspid leaflet might get caught. So that will be sometimes irritating, because once you pull the lead tip will be close to that leaflet, and at times it may damage the screw. So recently we had a case, I don't know where exactly. So it was again an online case. So it was just caught in the tricuspid leaflets. When we tried to pull it out, the lead screw got elongated, and ultimately we had to use another lead. So if it is going into the myocardium, then it won't be a problem. It will come back smoothly. You just have to remove the tissues and you can use the lead. Regarding the maximum number of attempts, it's all operator dependence. If you are persistent with doing left branch pacing, you can do it probably even 5 or 6 attempts. It won't be a big problem. The only thing is that if you are perforating into the LV cavity, you have to recognize it on table and pull out the lead and put it at some other side.
Dr. Last one permission for one last question. SMS, how often do you need to shape the sheath?
Probably 5%.
Okay.
Yeah. Thank you.
Yeah, that was an excellent session. Ullas, take over.
Dr. Sharma, again, you turned out to be the master of deep septal pacing from the country. And it is such a privilege to have you, especially with those pioneers, Pugal and Parikshit. Wonderful. I think you kind of clarified most of the practical questions raised by the audience and raised specifically by Ajay Naik. Ajay, thank you very much. Wonderfully conducted the moderation. And Venkateshan, sir, thank you very much.
Thank you.
That question of sick sinus disease and need for physiological pacing is so much debated. Thank you for bringing that up. And now another master of the physiological pacing from the country, and that is Dr. Neeraj Yadav, whose knowledge about this whole pacing technology is so amazing. He had been the speaker at many occasions. He had got papers about the physiological pacing. He's going to be now talking about his bundle pacing. And then Anup Gupta, my dear friend, another accomplished device specialist, and his skills regarding the conventional CRT is so amazing. We learned so very much. Looks like he's also kind of getting impressed with so-called this physiological pacing technology. Anup, welcome. And with Anup, we have the professor of cardiology and the head of the Department of Cardiology, one of the prestigious institutes in the country, and that is the Madras Medical College. Justin, warm welcome to you. It's a privilege to have you. Please accept our warm welcome. And I hope Madan Mohan is around. So Neeraj, you are going to be invited by Dr. Anup Gupta. Anup Gupta, introduce him and take over the session, please. And thank you.
Thank you, Ullas. It's a wonderful show for the last 4 days, and I should congratulate you for the same. It looks like a debate between left bundle pacing and his bundle pacing, and you have already chosen 2 masters. So to introduce Neeraj again is one of my colleagues and from my same city, very dynamic, bright, young electrophysiologist. He got trained in cardiology from GB Pan. Later he went to Dr. Jay Prakash in Bangalore for his EP training. And I would say Neeraj, probably in this western part of India, probably doing the maximum physiological pacing. So let's welcome Dr. Neeraj Yadav to deliver his talk on his bundle pacing, 2 interesting cases, and then we'll discuss the things. Over to you, Neeraj.
Thank you very much, sir, for that introduction. And thank you very much, Ullas, sir, and Chennai CSI chapter for giving me this opportunity to share my cases of his bundle pacing. So, yeah. So after a wonderful talk by Dr. Vijay Raman and Dr. Shanmuga Sundaram, I'm going to present these 2 cases of his bundle pacing. This will be actually both are cases of indication for prevention of pacing-induced cardiomyopathy, as well as treating dysynchrony. So this is the first case. This lady, 54-year-old female, she presented with history of heart failure, NYHA class 3 on optimal medical treatment for heart failure. And ECG was showing normal sinus rhythm, left bundle branch block, QRS 180 millisecond. Echo showed enlarged left ventricle with LV dimension almost 65 by 55, severe global LV hypokinesia, moderate MR, and ejection fraction of 20%. Cardiac MRI was done. It again showed enlarged LV dimension, 77 diastolic dimension, and ejection fraction of 18%. And there was no abnormal enhancement on delayed contrast study. So considering non-ischemic cardiomyopathy, left bundle branch block, and broad QRS, this was her ECG. QRS duration is almost 180 millisecond. So considering candidate of cardiac resynchronization therapy, patient was planned for CRTP with use of quadripolar LV lead, and then follow up clinically for improvement in heart failure symptoms and signs. So as we do in all these patients who undergoes cardiac resynchronization therapy, coronary angiogram was done, and which showed a reasonably good sized posterolateral vein, and it looked like a straightforward biventricular pacing case. Now, when we did a selective angiogram, what we looked at was that there was a tortuosity in the posterolateral vein, and this branch had a severe stenosis, which was difficult to negotiate without a support. So quadripolar lead, only 2 poles could get into this vein, and we then tried with a selective catheter and selective engagement of that vein. But however, that also didn't much help, and it led to perforation of that posterolateral vein. At this stage, we thought that probably we can get a wire and probably snare it out of the middle cardiac vein and finish the procedure. Probably that will give a support in negotiating the lead into the vein. However, in all of this struggle, we end up leading to CS dissection, and there was no vein filling with this CS dissection. So ultimately, we had to abort the procedure, and we explained the patient that procedure is unsuccessful, and probably we will try it later after 3 or 4 weeks, and we will do something else. We'll take help of the other hardwares. At this point of time, we didn't have actually his bundle lead and sheath in town, so we actually planned the procedure after 1 month. So after 1 month, patient came back, and this was coronary venous angiogram was done with AL2 catheter from femoral vein, just to look at the situation of coronary sinus. Dissection had healed well, but the same vein, again, very tortuous and very small caliber vein. So decision of his bundle pacing, considering angulated vein, which already we failed in that. So his bundle pacing was planned, and left bundle pacing, if his bundle pacing does not lead to correction of left bundle branch block, or in case of adverse lead parameters, we thought of pursuing the left bundle pacing. So mapping of his bundle is relatively easy when you have a normal RA and RV size. In this case, left ventricle was huge, but RA, RV were relatively normal size, and mapping of his bundle region was done with 3830 lead and C315 sheath. So just a small adjustment in this area, we could get a nice His electrogram, and this was the His bundle electrogram at the proximal His site. HV interval was 65, and pacing at this site led to selective His capture with no correction of left bundle branch block. Remember, these sites are not ideal sites for implanting a His bundle lead because you have a very near field, large atrial electrogram. Though you have a very sharp and very good His electrogram, this much of atrial electrogram can lead to problems of atrial oversensing and atrial capture. So proximal pacing did not correct left bundle branch block even at the higher output. So we just took our lead to the distal His bundle region, and pacing at this site led to correction of left bundle branch block. QRS duration from 180 millisecond, it reduced to 90 millisecond, and there was a selective His capture. During threshold check, as Dr. Vijayaraman told, that it is essential to have a 12-lead ECG and to see two thresholds actually. One is left bundle branch block correction threshold, as well as one His capture or myocardial capture threshold. So if you see, there is a left bundle branch block correction as output is reduced, left bundle branch, there is selective His capture, but left bundle branch block is there, and then there is ultimately loss of His capture. And this was the final site. So once the parameters were found to be satisfactory, sheets are removed. Adequate slack is given at this point of time, and parameters are rechecked. If they are satisfactory, you are okay to go ahead with a slit of this sheet. This was a final position of His bundle lead, and this was the final 12-lead ECG. So QRS duration from 180 to 90 millisecond, and selective His capture was achieved, which was quite satisfactory in this case. This was ejection fraction again, which was around 30% at 1 month follow-up. Sorry, I'm not able to play this video. So this was at 1 month follow-up, and at 5 months of follow-up, ultimately patient had a normalization of left ventricle dimension. So from 70 millimeter of LV, it became almost 48, 49, and systolic dimension of 27. Ejection fraction became 60%. This is important to understand in follow-up of this patient. When you see threshold check, you at least ideally you should have all the 12 leads, but without ECG, it would be completely misleading. So if you see, when we reducing the output at around 1.5, there is a narrow QRS, left bundle branch is corrected. From STIM to local EGM, there is a isoelectric interval. And at 1.25, all of a sudden, the QRS becomes widened. The local electrogram morphology changes, though there is a selective His capture there. So left bundle correction threshold was 1.5 at 1 millisecond, which was acceptable for a patient who already had a failed LV lead implantation. So let us follow up. Patient is currently an NYHA class 1. All heart failure medicines are stopped except bisoprolol 5 milligram once a day. ECG is normal sinus rhythm. A-sense V pace. Pace QRS duration is 90 millisecond, and echo has complete normalization of LV dimension with ejection fraction of 55%. There is no mitral regurgitation on follow-up. 99% of V pacing is confirmed with stable lead parameters. So His bundle pacing is definitely in patient who has a left bundle branch block, who meets typical left bundle branch block criteria. In majority of these patients, you can correct the left bundle branch block. The only issue is the threshold and output that is required to correct the left bundle branch block, and which are not acceptable in fair number of individuals. So we need to have a left bundle branch block pacing as a in all these cases. Now, coming to case number 2, again, this patient was a 71-year-old gentleman who had a chronic AV conduction disease. So he always had a first degree AV block with PR was almost 300 millisecond, 2:1 AV block, intermittent 2:1 AV block. And this AV conduction disease was there for almost in all his ECGs in past, maybe at least for last 2 years. He presented with heart failure, ejection fraction 25%, and coronary angiogram was done as a workup for left ventricular dysfunction, and it found multivessel coronary artery disease with a very critical left main disease. And nuclear imaging was suggestive of hibernating myocardium. So patient underwent bypass surgery, and patient was referred for us to have a post-op pacemaker implant. Now, when you see a patient who has recently undergone revascularization with ejection fraction of 25%, it is you're not sure whether patient is going to require ICD in future. So because patient had a chronic AV conduction disease for last 2 years, we advised him for medical follow-up and asked him to undergo pacing or ICD implantation after 3 months. Patient on follow-up after 3 months, patient had ejection fraction of 50%. So the CABG improved ejection fraction in hibernating myocardium, and however, patient had ejection fraction of 45 to 50% with persistent of symptoms of heart failure. ECG and Holter confirmed 2:1 AV block, and this was his ECG. So if you see there is a prolonged PR interval with 2:1 AV block, suggestive of AV and narrow QRS complex, suggestive of AV conduction problem at the AV nodal level. And this actually low voltage is in lateral precordial lead and inferior lead because of pleural effusion in this page. So we planned a His bundle pacing. There was a mild LV dysfunction, heart failure symptoms. There was no indication of ICD now in this patient. So patient underwent His bundle pacing. And this is again a
I'm extremely sorry for the interruption, sir. 2 minutes of the screen time left. Thank you.
Yeah. So this was mapping through Medtronic 3830 lead, and you could see that there is a 2:1 AV nodal block, suprahesion, a very sharp His bundle potential, and a normal HV interval. Atrial electrogram was small compared to ventricular electrogram, and pacing was done at this site. And this is a selective His capture. You have isoelectric interval from STIM to QRS, and there is also gap between stimulus to a local ventricular electrogram. Thresholds were very impressive. Throughout the threshold check, patient had selective His bundle capture. This suggests that probably this is being paced at the proximal His bundle site without any intervening myocardium. So it is probably subendocardial His bundle location. Whenever you see this kind of response, it is very important to pace at very fast rate. We went up to 140 and ensured that there was 1:1 downstream conduction during pacing. So once it was there, we accepted this site, and there was selective His capture up to 0.5 millisecond at 1 millisecond pulse width, 0.5 milliwatt. So this was the final ECG. If you see selective His capture is there with AV pacing. And this is in follow-up when patient had improvement in heart failure, reduction in pleural effusion, voltage is improved in the electrogram lead. And at follow-up, you could see a nice His electrogram in pace sense analyzer. So there is an atrial electrogram, which looks like far field, near field, His electrogram, and ventricular lead. So again, at present, patient is completely in NYHA class 1. Only on DAPT and statins, there are no heart failure medicine now in this patient. ECG is normal sinus rhythm, A-sense V pace, pace QRS duration is 80 millisecond, echo is normal, ejection fraction 65%, and stable lead parameters. So, should I go to questions that are posted?
I think we can take the discussion, Neeraj, because I think your time is almost up.
Okay.
That is what she said.
Okay. Okay. Yeah, fine.
So wonderful cases, Neeraj, and very elucid presentation. To start with, I would like to ask you a couple of things. The first case, like you said, that the LV dimension was 77, and you were extremely lucky. After doing his bundle pacing, it came down to 47. That's quite a lot of remodeling. Now tell me, how often you require extension of the sheet 315 to get his bundle position to place a lead, because sometimes it's a dilator, it's sometimes very, very difficult. And secondly, what is the threshold you accept for the his bundle in LV dysfunction cardiomyopathy patient? Because most often we see the threshold is on the higher side, and when you want to switch over to left bundle pacing.
So my threshold of choosing means patient for his bundle pacing correction CRT. Usually I look for two things. One is typical left bundle branch block according to Strauss criteria, and second thing, RA and RV dimension. So if RA and RVs are pretty normal, I am confident that his bundle pacing can correct the left bundle branch block. In dilated right atrium, right ventricle, it is difficult to map this his bundle region, and left bundle pacing is now the first strategy in such patient. So normal RARV, his bundle pacing is first thing to do. Check the parameters. If correction thresholds are okay, lead parameters are fine, you can stop there. If it is dilated, I try for once or twice just to have an idea of where the his bundle location is. Otherwise, I straightway go to left bundle pacing.
What is the cutoff threshold for his bundle?
Yeah, so I have kept for CRT purpose, my threshold is relatively higher, because we also accept output of 2 in LV lead. So my acceptance is around 2 volt for at 1 millisecond pulse width for CRT indication. For pacing indication, it is less than 1.5.
Okay. And regarding the second case, post-surgical case, again, you waited for 3 months. Many a times, we don't wait for 3 months. If the patient has got a complete heart block upfront, and we know that this patient requires a pacing. So do you still recommend, after surgery, before discharge, you can still go for a his bundle pacing?
Yeah, so in this case, I waited because pre-operatively patient had an ejection fraction of 25%, so nuclear imaging. So I just wanted to wait because if patient's LV function doesn't improve by bypass surgery, that means that patient is probably going to require a primary prevention ICD also. So, and patient had a chronic AV block. He has remained in AV block for last 2 years. It is an AV nodal block. So there was no harm in waiting for 3 months for to see what is happening to LV. So I told my surgeon that, look, if he comes back with same ejection fraction or less than 35, probably he will need ICD. That's why I'm not going for pacing right now. And he has been in AV block for such a long time.
Suppose the LVEF would have been 50% at the time of surgery. What you would have done? You would have done his bundle before discharge, or call him back again.
Yeah. So if ejection fraction was 50%, so the only reason why I waited for 3 months was to see whether he is also a candidate of ICD. Otherwise, if patient had a normal ejection fraction or 50% ejection fraction, I would have gone with his bundle pacing at the same hospitalization.
Great. Dr. Paul, you want to ask anything?
Yeah, thank you, Dr. Neeraj, for your presentation. I have a much simpler and a more basic question. Now that the his bundle pacing, we claim that is more physiological and it may not have the complications of RV pacing, leave alone the heart failure and CRT indication. Do you think it is going to be the standard of care for every pacemaker indication? Like whenever you want to pace in for a AV block or a six sinus syndrome, whatever pacing, is it going to replace the RV pacing, remembering that the thresholds are going to be 2 or 3 times high and the replacement rates are likely to be more and the fluoro time and the radiation is going to be more than this? What is your comment on that?
Yeah, so even I don't do his bundle pacing in almost all cases. I look for the incremental benefit of his bundle pacing over RV pacing. So if patient is having six sinus syndrome and you can avoid ventricular pacing in this by checking other parameters, what is the AV conduction,
Let us
faster
assume
pacing rate, what is the baseline?
Let us assume he needs RV pacing. Let us assume he needs RV.
Yeah, so if he needs RV pacing and RV pacing is going to be there for more than 30% of time, my first choice would be his bundle or physiological pacing. So yes, there are issues with threshold rise, which has been corrected and which has been taken care by left bundle pacing, which is again a physiological way of pacing. So where threshold at the time of implantation is normal, usually I have not seen very big, much problem with those cases. But when you accept threshold of higher threshold at the time of implant, probably those are cases where you are going to have a much problem. Also, I have not seen problem of threshold rise in a patient who has a narrow QRS complexes. So in those subset of patients, his bundle pacing I would try. In infrahisian AV block, left bundle pacing or left septal pacing would be the strategy forward. Would it become popular? That depends on further refinement of tools as well as keenness of learning this technique by the operators. Ultimately, if once technique becomes easier by the tools, and it will become popular, because once you go start doing his bundle or left bundle pacing, it is very difficult to move back to right ventricular pacing.
Thanks, Dr. Neeraj. There is one more question from the floor from Wasim Rashid. Most of the times there is a micro displacement during screwing at his bundle. So, you may lose the sweet spot. Do you have any tips to overcome this frequently encountered issue?
Yeah. So one thing, lead dislodgement is not very different from the routine right ventricular lead with this 3830 leads. In fact, lead dislodgement has not been found, in my experience at least. There can be threshold rise, the mechanism can be micro dislodgement, or there can be other reasons, because ultimately you are screwing in the membranous septum. What is the response to injury by helix to that region? And also the lead is not, it is just a steroid, it is not a steroid eluting lead. So those are the issues of this lead. And that's why probably the threshold rise is seen in 10% of individuals. I would say that dislodgement at the first micro dislodgement or dislodgement of the lead, you have to ensure the stable parameters at the time of procedure. So one key that is most important is to not to accept any adverse parameters at the time of implant itself. If your outputs are good, if your thresholds are good, if you have chosen a site where there is a near field His electrogram and a far field atrial electrogram, which is small, usually you don't find issues that are very typical of His bundle region, like atrial oversensing, ventricular undersensing. So procedure parameters are very important.
There is a question from
couple of more questions. So Yash is asking, like, if patient is going to be totally dependent on pacemaker, would you accept pure His capture without any mitral capture? And is asking or His bundle pacing.
So yeah, so first is I couldn't hear the second part of the question. First question means I would not be very comfortable in a patient who has selective His bundle capture in patient with infrahisian or intrahisian blocks. So whenever there is a pure AV nodal conduction problem and you have a selective His capture without any non-selective response, in last case, actually the same thing was happening. Patient had a selective His capture only. So this His bundle was probably subendocardial. There was no intervening muscle cells to result into non-selective capture. And but then you have to make sure that there is no downstream conduction defect by pacing, by stressing this, at a various by various means, like pacing at very faster rate or doing extra stimulus testing through the pacing lead. So when it is not there, I would be comfortable. But in distal conduction problem, I would make sure that there is some non-selective response also.
Okay, thank you, Anup. Thank you, Justin. You see, I think there is a question from Archana, which he could not hear, Neeraj Yadav. This is something with the DXICD lead at the His bundle. I think you are aware that, I have got some series of cases which I have done DXICD with, but then it's like on an experimental basis that is not approved. You need to be having, I think a lot of skills, and, you should be lucky to do the pre-shape. And there are several issues and lots and lots of issues. And few of the cases where we have attempted, I think I presented to all of you people recently. There were 3 cases which I presented. I think it is possible. It's possible, but presently it is not recommended. If you have really counseled very well with your patient, well, you can very well do. That I think could be the coming days. It should be possible. But Neeraj, masterly presentation. You are known. You are respected for your His bundle pacing. Anup, you took over the session very well. Justin Paul, thank you very, very much for being around. Please continue to be staying around, because we have the master of the physiology. And Parikshit, welcome. And, it's such an honor to have you on our screen. And, we are going to be learning a lot today. We heard the anatomy, the electrograms, and then the left bundle pacing, septal pacing, His bundle pacing. And now the utility of this is, I think, is enormous when we now extend this physiological pacing concept for heart failure patients. So you are the right person, Parikshit, and we are honored to have you, and welcome. And to introduce you, we have another stalwart of electrophysiology and pacing in the country, who also happens to be the president of Indian Heart Rhythm Society. So Cardiological Society of India, is proud to have Dr. Anil Saxena and Dr. Parikshit. And Anil Saxena, over to you, and you are going to be ably accompanied by one of the senior cardiologists, professor, and academician, so much respected in the city of Chennai in Tamil Nadu, Dr. Vaidyanathan. I can see Vaidyanathan on the screen. Welcome, sir. And over to Dr. Anil Saxena to introduce Parikshit Sharma and then carry forward. Thank you.
Thank you. Thanks, Dr. Ulas, and congratulations once again for organizing such a wonderful program. Good evening, friends. First of all, I welcome my co-panelist, Dr. Vaidyanathan, to this very interesting and very important session. And it's really a privilege to introduce Dr. Parikshit, who in a very short period has become a star in EP community in India. Dr. Sharma is an associate professor of medicine, academic clinical cardiac electrophysiologist, and director of electrophysiology lab at Rush University Medical Center in Chicago since 2016. He serves on ACC EP SAP question writing committee, and he's also on the editorial boards of Heart Rhythm Journal and Circulation Arrhythmia and Electrophysiology Journal. Dr. Sharma has more than 80 original peer-reviewed publications and over 100 abstracts at major scientific meetings, and he has published extensively in high-impact journals like Nature, JACC, Circulation, and Heart Rhythm. His work on his bundle pacing as an alternative to biventricular CRT received the award for the best publication, and that's also the topic for today in the HRS 2019 at San Francisco. And he was also an expert panel of physicians that published a position paper on his bundle pacing in Heart Rhythm 2017 and was named Next Gen Innovator in Cardiology in 2017. And he has played a pivotal role in starting the Rush Comprehensive AF Center and has contributed to the program tremendously. Dr. Sharma will speak today on his bundle and left bundle pacing for cardiac resynchronization therapy. Over to Dr. Sharma.
Thank you. Thank you, Dr. Ullas, Dr. Saxena, and the rest of the IHRS team and the council. It's my honor to be here. I know we've come a long way in this journey, and can you guys hear me okay? I'm sorry, I'm having some connectivity issues, seems like. Hello?
Yes, we can hear you.
Okay. I'm not sure why, but my laptop seems to be crashing on me, which is not a good thing right now. But the idea of, as my presentation pulls up here, to talk about his bundle pacing or left bundle branch pacing for cardiac resynchronization therapy is relatively newer. It's not something that we know that traditional CRT is by the CRT is what we refer to as traditional CRT, is the conventional form of CRT, and these are newer modalities that have just started emerging, and there's a lot of excitement associated with them. I apologize, my computer just restarted in the middle of this Zoom call, which is not necessarily the best thing, but I'm trying to do my best to open up this presentation. Do you guys see my screen?
Yes, it's a static screen.
Okay. Do you see my slides at all?
Yes, but okay. Can you make it in the presentation?
Yeah, I am putting it in presentation. Is that good?
No, not really. It hasn't changed at all in the last 3 minutes, actually. So,
it might be stuck.
You need to share again, probably.
Yeah, let me do that. It's asking me to join the meeting again.
Yes.
Dr. Saxena, I think Dr. Clare is not around. That's the...
Yes, I didn't see him actually because he was supposed to join this meeting.
So
I haven't seen him. And
well, it would have been wonderful to have him too.
Absolutely.
Okay, do you see my screen now?
Oh, yeah, it's the same screen. Yeah, now it's better. Yeah, of course. Now we can see it.
Okay, Perfect.
Thank you.
I apologize for the inconvenience. So okay, so those are my disclosures. And we know that cardiac resynchronization therapy with biventricular CRT has its advantages and includes improvement in heart failure, LV systolic function, reduces heart failure hospitalization, and improves survival. But there are certain challenges, and those are about a 30% CRT non-responder rate, about 2 leads to pace the myocardium, the RV and the LV, pacing the LV epicardium, which is not physiological, and that can oftentimes result in a non-physiological ventricular activation, especially in patients with a narrow QRS. So I'm going to look at each indication for CRT and break them down and present some cases. So the first indication is a patient with a typical left bundle branch block. And here's a patient with a cardiomyopathy and a left bundle branch block with an ischemic cardiomyopathy and comes in for a BIV-CRT implantation. Can you still hear me okay? Hello?
You need to share your screen again. We can't see your slides.
Good evening, sir. Do you need any kind of help from us, sir?
Well, I'm having issues. I don't know whether it's internet connectivity because my Zoom app seems to keep shutting down here.
Your video is okay, hence Zoom app may be all right. Is it something to do with the laptop? You will again go out and come in something?
Yeah, can you guys, can you give me just 1 minute?
Maybe you can close some of the other programs. There were plenty of programs open.
Yeah, I'm going to shut everything and log back in if that's okay. Just give me 1 moment.
We are waiting. Don't worry. Absolutely. Take your time. It's important for us to listen to you. Saxena sir, till he comes back to us, I may ask you a few things. Is that okay?
Yeah, sure, absolutely.
Just was wondering. So there are occasions where, for example, we have planned for a CRT and then we are getting into the lab for the CRT, conventional CRT, and we also know that there could be a reason or multiple reasons where we'll not be able to achieve on table either the hemodynamics or the limited ECGs, and there are many ways where we think already we know that we probably are not going to be getting a good response to this therapy. At that time, we should be going, I think, for the his bundle. But then there are certain technical issues about the vendors.
Yes.
milliseconds to 90 milliseconds. We then decided to map even more distally, and we found an even more distal site with a much sharper His and a far-field looking atrial electrogram. And you can see this was even more superior and anterior. So we went from about here to here to here. And pacing here resulted in selective capture of the His bundle with a QLV that was down to 70 milliseconds and a much better result with a pace QRS of 90 milliseconds and a threshold of 1 volt at 1 millisecond. So the idea really is to map the portions of the conduction system that can give you the best possible result. You could find a His electrogram and have a high threshold, but if you didn't map the entire region of the His bundle, you cannot truly say that you're absolutely distal to sited disease. Here's another example of a patient with a left bundle branch block and a non-ischemic cardiomyopathy. And you see here, we performed again that same concept of the CS venogram, subselected a lateral branch and placed the vision wire in that lateral branch. And we started with a QLV of 170 milliseconds. And we then started performing His bundle mapping. And we found a beautiful His with the injury current, but the HV interval at this location was 70 milliseconds, which is at the distal most site we could find, and probably on the higher end of what you would accept as a result. Now, we did pace at a high output, and we got a QLV of 110 milliseconds from 170 milliseconds, and this is the RAO projection of where we were mapping. So some would accept this as a good result, but the threshold for correction was 2 volts. And so we have changed our practice where we try not to accept a correction threshold more than 1.5 volts at 1 millisecond. And so we decided to go down to map the left bundle branch region. And you see here that this is the lead in the septum at the left bundle branch region. There is a left bundle potential, which is not, this is not gained up enough, but this is His pacing, left bundle potential. And you see that your QLV with left bundle branch pacing is 100 milliseconds as opposed to 110 with high output His bundle pacing, and much shorter compared to the baseline QLV of 170 milliseconds. So in this patient, using this method, we were able to identify that left bundle branch pacing would be our best strategy in terms of shortening the LV lateral wall activation time and giving you the best combination of low thresholds and best LV activation. This was the final pace QRS in this particular patient with bipolar left bundle branch pacing. So we know that there's data. The earlier study was by Dan Lustgarten, who did a beautiful study with crossover design of patients receiving both a His bundle and a left ventricular CS lead, and crossed these patients over at 6 months within themselves. So it was a single-blinded crossover study where he demonstrated that both His bundle pacing and BIV pacing resulted in a similar response in ejection fraction, NYHA functional class, quality of life, and 6-minute walk. More recently, the His Sync pilot study was reported. And yes, there are people that believe that His bundle pacing did not achieve resynchronization with a high percentage. But one of the reasons why the group that was assigned to His CRT had a high degree of crossover was because, unfortunately, in this trial, there were a lot of patients that were included that had an underlying IVCD, and we're very well aware that His bundle pacing cannot correct IVCD patterns. In fact, 25% of this cohort had IVCDs. But when we look at the patients that were successfully achieved His bundle pacing, you see that His bundle pacing resulted in a more significant drop in the QRS duration, higher improvement echocardiographic response rate, and a higher change in mean left ventricular ejection fraction by about 9% compared to 5% with BIV pacing. Now, what about patients with a non-left bundle branch block pattern? So here's an example of a patient with a non-ischemic cardiomyopathy, a right bundle branch block of 148 milliseconds and a very long PR interval. And coming to one of the points that Dr. Yash made earlier, looking for split potentials. And here's an example of mapping in the his bundle region fluoroscopically at this particular location in an RAO projection. And you see an AH of 300 milliseconds and HV of 150 milliseconds. And this would definitely be a proximal site because the HV is very long. You definitely would not want to accept this. Although at a pacing output of 2.5 volts at 1 millisecond, we completely narrowed this right bundle branch block pattern. This would still not be an acceptable site. So in this case, we reshaped the sheet to try and get more anterior and superior, and we're able to find the distal His potential with an HV interval of 45 milliseconds. And you can see fluoroscopically the distance between the two sites of less than 0.5 centimeter. And this was the final pace QRS in this patient with complete normalization of right bundle branch block pattern and a final pacing threshold with correction of less than 1 volt at 1 millisecond. So that emphasizes the importance in patients with bundle branch block or those patients that are undergoing CRT therapy to adequately map the His bundle before you say this is not an acceptable result. And so this was another area that we did a lot of work on, myself with Dr. Vijayaraman, and you see that with His bundle pacing in patients that have a cardiomyopathy and right bundle branch block, we demonstrated high echocardiographic and clinical response rates of about 65 to 70% and about a 20% super responder rate, no matter what the reason or what the mechanism of achieving QRS narrowing was, and no matter how wide the right bundle branch block was at baseline. Even those patients that had a right bundle branch block pattern less than 150 milliseconds seemed to have a high rate of response. Finally, patients with pacing-induced cardiomyopathy, we know that a lot of these patients end up getting upgrades to traditional BIV-CRT. And here's a patient with RV pacing with a very wide QRS and an intrinsic escape rhythm with a right bundle branch block pattern. And you can see that with His bundle pacing, we were able to completely correct the right bundle branch block pattern. And this patient demonstrated a complete normalization in his EF and follow-up. And we've published on this as well now with Dr. Vijayaraman being the first author on this paper, where out of 83 patients, we were able to demonstrate with 60 patients of this cohort had pacing-induced cardiomyopathy, and some of them just underwent a revision to a dual-chamber pacemaker with His bundle pacing leads, and a significant decline in a decrease in the QRS duration with His bundle pacing, and a significant improvement in EF from about 34 to 48%, and improvement in functional class as well. And finally, those patients that undergo AV nodal ablation, particularly those that have a narrow QRS at baseline, His bundle pacing or physiological pacing would be the ideal modality in this cohort of patients. And there's publications both from Dr. Vijayaraman and Dr. Wong in this arena. And I'm not going to dive into these cases. This is just for reference. This was the paper that we published a couple of years ago that we were honored by at Heart Rhythm last year. And this is a multi-center experience looking at 106 patients. Group 1 was patients that failed of CS lead implant, and Group 2 were patients where we attempted His bundle pacing as a primary strategy for CRT, where we demonstrated in this cohort of patients that His bundle pacing was successful in achieving CRT in about 90% of this cohort, and significant improvements in LV ejection fraction and improvement in NYHA functional class, irrespective of the indication for cardiac resynchronization therapy. Overall response rate was about 73% with a super responder rate of about 40%. This is just a schematic of beautifully demonstrating how we have understood His bundle pacing and its correction of dyssynchrony over the decades, starting from Dr. Narula back in 1970s and going on to more recent work that we have done back until 2019. And that then brings us to the next, this is just a table in the Nature Reviews paper for your reference that talks about all the studies on CRT that have demonstrated the benefits of His bundle pacing. That then takes us to the next aspect, which is left bundle branch pacing. And as has been highlighted by Shanmuga and Dr. Vijayaraman, this is a relatively new kid in town, and it has helped us overcome some of the challenges with inability to to recruit bundle branch block physiology in that 10 to 20% of cohort, we can now achieve bundle branch correction with 95+% success rate once we add left bundle branch pacing to our armamentarium of physiological pacing. So I showed you some examples of this already. And this is, again, I wanted to ensure I put this paper in. This is beautiful work. This makes us proud. Shanmuga with Dr. Nambudiri, Dr. Vanitha, Dr. Vijay Raman, all of them have collaborated together on putting this beautiful paper together with this nice table that beautifully highlights all the data there is on left bundle branch pacing. And this latest study by Dr. Vijay Raman with a large cohort of 325 patients looking particularly for left bundle branch pacing in patients with CRT eligible patients, demonstrating a very high response rate. So this is my current or our current understanding and our current schematic of how we proceed for CRT when we consider physiological pacing. We start with His bundle pacing as the first step. If the threshold for correction is more than a 1.5 volts at 1 millisecond, we will move to left bundle branch pacing. And if we are unable to get a good result with that, we would proceed to traditional biventricular pacing. And then one subset that we didn't really talk about, and it would be beyond the scope of this 15-minute talk, was those patients with an IVCD pattern. So in those patients, you could consider, especially in those patients that have a very massively dilated ventricle, like was highlighted earlier, you could combine conduction
Sorry
system
for
pacing.
the interruption, sir. 2 minutes of the screen time left. Thank you so much.
Thank you. So in patients with an extremely dilated ventricle, you could consider combining His bundle pacing or left bundle branch pacing with CS pacing to achieve the best physiological or multi-site pacing possible in these patients that could give the patient the best possible chance of recovery in LV function. So what are the limitations with His bundle pacing for CRT? We know that like biventricular CRT, His bundle pacing may not be successful in all cases. There are challenges with anatomy and the level of disease. There are limitations with the current delivery system, and there are challenges with expertise and experience over time that have demonstrated that experience can help us get better results. There are issues with increase in His bundle pacing capture threshold and recruitment thresholds, with current data suggesting it's about a 10% rate. And hopefully with better tools and more understanding of what the limitations are from, we would be able to overcome those. And finally, the biggest issue is there's lack of randomized controlled data, with BIV having data for about 2 decades, while His bundle pacing lacks that. And until we have that, we should not promote this as a mainstream for CRT in those patients that can afford a regular 3-lead system. Similarly, left bundle branch pacing does have its limitations as well. And there are challenges with anatomy and level of disease, with delivery systems, especially in patients with an extremely dilated heart and with experience. There may be concerns for lead dislodgement or with intraseptal perforation. We just recently published a case report in Heart Rhythm that of a perforation that occurred 3 or 4 weeks after implantation into the LV cavity. And again, similar to His bundle pacing, we still don't have head-to-head randomized control trials comparing left bundle branch pacing with traditional BIV CRT. So to conclude, BIV CRT has a 20-year track record. However, in some cases, it may fail to achieve adequate resynchronization and might even create dysynchrony. So I think the most eligible candidates for physiological pacing for CRT are when you're using it for rescue strategy. For those patients that have a non-response to traditional BIV, as we've seen in some of the cases today, for those patients undergoing an AV nodal ablation and have a narrow QRS to begin with, and for patients undergoing an upgrade for pacing-induced cardiomyopathy. And conduction system pacing may be an alternative to biventricular pacing for CRT, but we need more large-scale randomized controlled trials before we can say this is the best first-line therapy for cardiac resynchronization. Quickly, just to answer some of our questions. So in the first case, I think we present the case of a patient with an ischemic cardiomyopathy post-resuscitation. So it's a secondary prevention indication. So clearly this patient requires an ICD. And what would you choose? Again, based on everything that I have shown you, with the lack of enough head-to-head randomized data, I think I would still recommend a BIV-CRT as the first-line option for this particular patient. In the second case, again, this patient is non-affording, which is like a lot of patients that we see in India and our part of the world. In a patient with a non-ischemic cardiomyopathy with a gradual decline in LV ejection fraction, again suggesting that dyssynchrony could be responsible for this decline in EF. Here, just being able to resynchronize this patient with whatever strategy might be the best option. And here, in a non-affording patient, either his bundle pacing or left bundle branch pacing with the dual chamber pacemaker might be sufficient. And finally, coming to what would you accept as the endpoint if you take the patient from question 2, what would be the best endpoint? And here, clearly, I'm sure people are split between his bundle pacing or left bundle branch pacing, but here it is important to understand some of these parameters. So here we have a patient with his bundle pacing with non-selective capture, a QRS of 110 milliseconds from about 170, a threshold of 1 volt at 1 millisecond. With left bundle branch pacing in the same patient, you have a threshold of 0.5, an impedance of 300, and the similar QRS. What would you accept? The right answer here would be his bundle pacing, and the reason for that is if you get an impedance of 300 ohms with left bundle branch pacing, that is not a good result. That probably indicates you have screwed the lead in too deep and you are looking for a potential imminent perforation to happen. So any impedance less than 400 ohms, I would be very careful with accepting left bundle branch pacing as the outcome in that particular case. Thank you, and let's open it up for questions.
Thank you, Parikshit. That was excellent. So maybe I can begin by asking you a question. Now, you see, in the end, you told there are 3 potential indications of his bundle pacing for achieving CRT. One is it could be preferential his bundle pacing in place of CRT. That is, a time is probably not ripe unless we have a randomized trial showing benefit. So that is something which we can put off right now. Second is as a rescue procedure when you're not able to place the LV lead properly. That probably is the most important indication. And third, if I may call it a reparative kind of indication where patient is a non-responder and you want to improve the lot. Now that's a very diverse group of patients. Some of them may have a poor LV lead position. Some of them may not be capturing well. They may be anodal capture, or there could be intraventricular conduction defects with a lot of scar tissue where the impulse is, whatever you do, the QRS is going to be wide. Or some of them may be having a lot of totally damaged ventricular muscle like scar tissue. You can't, whichever way you do, you can't stimulate that. So which of these you think will be a better responder to his bundle pacing among the population of non-responders? Do you think the response will be different?
I think that's a very, very good question. So in the study that I showed with the multi-center experience, we did have 8 patients in that cohort that were non-responders to traditional BIV-CRT. And when we say non-responders to BIV-CRT, we are responsible to make sure that they're truly non-responders because we have done everything with BIV and that has resulted in lack of response, which is just like, we've adequately controlled the AV delays, we've programmed VV delays, optimization the best possible way we can. The LV lead position is optimal. We have controlled arrhythmias, anemia, all the traditional reasons we know BIV non-response occurs before we say, okay, they're truly a non-responder. So that's the first step. The second thing you come to is you look at the underlying QRS complex and the underlying anatomy of the left ventricle that we're dealing with and the underlying pathological process. So if it is an extremely dilated LV of 8 centimeters with IVCD and not a typical bundle branch block, the disease is probably multi-level in those patients. There may be some conduction disease, there may be intramyocardial disease, there may be more distal disease. In those patients particularly, like I highlighted, I think considering an addition of a conduction system lead to the biventricular system with hot CRT or LOT CRT might have some incremental benefit. but we still don't have, a definitive answer to that. But again, those patients are struggling. They may not necessarily have the means to have a heart transplant, or they may not be young enough to get a heart transplant. And that's where we're scrambling for what can we do to help this patient. And so I think considering conduction system pacing in combination with CS pacing might be the best resort after we optimize everything else. The second subset is patients that you've done everything for to optimize non-response, but they have a typical bundle branch block, and maybe they're just not responding because of the non-physiological method of activation of the left ventricle. And so if you have a typical left bundle branch block, I think that's a subset of patients that might actually do very well with conduction system pacing. And it's surprising, we initially thought that it would be those patients with a non-ischemic cardiomyopathy that will stand out and do very well. But we've seen a number of patients with ischemic cardiomyopathy as well that have demonstrated a normalization of their ejection fraction if you get a complete narrowing of the QRS and the disease is predominantly in the proximal conduction system. So I think those are the two subsets. So I think it's very important, number one, to start with what is the non-response from? Correct all the potential reasons. And then after all of that, if they're still not responders, then consider one of those two options depending on what you think your patient would benefit from the most.
Thank you. Dr. Yash has asked a question. So among the RBBB or non-LBBB morphology patients with heart failure, one of the ways to identify patients who could be potential responders is by looking for some evidence of LV conduction delay, like for example, left axis deviation or high QLV duration. And that's how we pre-select those patients among that population of RBBB and non-LV. So if the axis is normal or rightward and the QLV is normal, do you think there is any point doing attempting physiological pacing to achieve CRT if they don't have any brady indication? Would you consider Hisnal pacing in that population?
So if you have a patient that truly has a decreased LV ejection fraction or heart failure, and there's no other potential etiology for the same, and you feel like they may potentially benefit from CRT of some sort, I think in looking at the study that I presented, we did have those same questions, is that we've implanted these leads in patients with a QRS duration of 130, 140 milliseconds, which is not traditionally what we do for biventricular CRT. And do those patients actually benefit? So we broke it down based on the QRS width. We broke it down based on the underlying PR interval. We broke it down based on just right bundle branch block or right bundle branch block plus left anterior fascicular block and left axis deviation. And we did not see any clear signal towards a difference between outcome differences in any of those cohorts. Now, granted,
the numbers were small.
Yes,
maybe
granted, yes, absolutely. Granted, in a couple of those analyses, the numbers were small. But when we broke it down based on PR interval plus right bundle branch block or no PR interval and a narrow right bundle branch block, we didn't see a significant difference in the outcome. So truly, I do believe strongly that there may be value. Now, I don't think I would take a patient with a QRS of 120, but if a patient has a QRS of 140 or 150 and has no other potential option and they've maximized their heart failure therapies, I think it might be worthwhile trying. You could even put in a dual chamber system with physiological pacing, and if you can achieve resynchronization, their heart failure might potentially improve, although it won't respond with the same
QLP duration. You wouldn't want to look at the QLP, okay.
You certainly could, just like I showed in some of those examples by putting in one of those vision wires, look at the QLV. But if on ECG, they don't have a left axis deviation or they don't have left anterior posterior fascicular block, I doubt we're going to do much more to change left ventricular activation times in those cases. And maybe there's a component of the septal dysynchrony that has contributed to their dysfunction. And we don't absolutely understand those mechanisms 100% at the present time either. So,
thank you. I think so. Parikshit, what's happening in the future? I mean, do you think some more tools are coming, or something is happening? More manufacturers coming with new leads or something? What's happening in coming months and maybe a couple of years? What's happening on the hardware front?
Yeah, I think over the course of the next 3 to 6 months, you will see a delivery system with every manufacturer. So St. Jude or Abbott already has their delivery system that is not commercially available, but available to some of us for study reasons. And we've helped with designing a lot of these. That sheet actually has electrodes at its tip, so you can actually record electrograms and paste with it. But it is going to be expensive to start because it's a mapping and recording system. Boston Scientific already has a multitude of sheets that have been out for delivery of leads to the bundle of His and potentially at the left bundle branch region. And Biotronic also has systems that are available in India as well as in some parts of Europe now for trial purposes, and we should have results on those. I think the next step really is going to be, are the current leads that some of these manufacturers have good, better, or worse compared to the 3830? I think what was highlighted earlier was the 3830 has its advantages. It was clearly not a lead that was designed for conduction system pacing. It was a lead that Medtronic got lucky with because it was a pediatric lead and it seemed to work well in this area. But the lead is not steroid eluting. It's steroid coated. And we all know when we try doing these cases, oftentimes you have to try multiple times and you have to clean off tissue from the tip of this lead. How much steroid actually gets left behind? Is there any at all at the tip of this lead? How does that impact thresholds in the long term? So those are all the unanswered questions. And maybe some of the increase in thresholds that we see with his bundle pacing are potentially related to the steroid. And we don't know the answer to that yet. But maybe some of these newer leads might solve that issue. But the other challenge also is the existing leads with the other platforms are also bigger. They're a bigger dimension. They're 6 French or 7 French leads as opposed to a 4 French lead. So it's a heavier system at the tricuspid annulus. That's one issue. The second is their active fixation leads, extendable retractables. Is it easier or more challenging to implant those leads at that region is yet to be answered in the hands of mass implanters, right? So all of those are questions that need to be answered. But the one thing we don't have is a dedicated delivery lead for conduction system pacing, which I know a couple of manufacturers are starting to work on, but it will be years before we have that available. But the honest truth is, for all of those people that have questions about this and have not seen the excitement in their own practices, I think the way to look at this is like the early CS implant days. I mean, I'm young enough. I know a lot of you guys have a lot more experience with that and have been part of some of the early trials and seen how CS implants have evolved over the years with bipolar leads to quadrupolar leads to one sheath for delivery to multiple sheaths with snaring systems and all of that. And I think there's a good possibility that conduction system pacing will see a similar evolution. But this is going to be driven more by the physicians that are believers than the industry, because there is not much more to gain for industry here. They're still going to sell the CRT devices the same way. It's just which lead they sell. So I think if we feel that there's value in this, we have to be on the forefront of investigating it, and we have to demonstrate the enthusiasm to learn it and to push this field forward.
Thank you. Those were amazing insights. Dr. Ulas, do you have any question or comment? Dr. Vaidyanathan.
Wise man, he's the most senior and most respected cardiologist of the city. His wise words, I would like to hear. I'm sure he must have appreciated so very well. He has been seeing ever since the pacing concept came into existence. He's the right person to give some final comments. Dr. Vaidyanathan, welcome. I'm eager to hear some comments from you.
Thank you, Ullas. I have to thank 2 people, the CSI Chennai chapter and Dr. Ullas. The 4 days are very excellent. See, I am a general cardiologist. I am not an electrophysiologist. I am able to learn a lot in this past 4 days. I learned the terminologies. I know the procedures. I always tell the young
Anyway, I think we seem to have lost connection with Dr. Vaidyanathan. His words are, full of wisdom. He's the respected cardiologist of the city. Parikshit, how do I thank you? You have been always willing to be sharing your knowledge and the expertise, and the last comments of yours, such visionary as our Heart Rhythm Society President, Dr. Anil Saxena, what he said. We truly are honored, Dr. Parikshit. You always are willing to share your experience, your expertise. And in fact, in India, we are all inspired by your work, your knowledge. And, we are proud of Shanmuga Sundaram and Neeraj Yadav solely because, you imparted the knowledge to them. So with these words, ladies and gentlemen, the fifth day of this Cardiac Rhythm Council Digital Summit is coming to an end. And I take so much of a pleasure and pride to say that, they all, the stalwarts of this physiological pacing were there with us. And there's another news that today we crossed 1,000 registrations today. And at any time, there were more than 250 active participants. This is an immense and tremendous response to this Cardiac Rhythm Council meeting. I feel so encouraged. And tomorrow, again, we have the last day session. Again, it's going to be discussing with the issues of syncope, sudden cardiac death, and some acute conversion of atrial fibrillation to sinus rhythm, etc. Again, some stalwarts are coming tomorrow. I wish you people again log in. And again, thanking everybody, Saxena sir, Parikshit, and everybody who is still around. It's wonderful, and I wish that you people log in tomorrow. With these words, let's conclude today's session, and good night, and bye-bye.
Thanks. Good night. Bye.
Thank you. Thank you, everyone.